Professor Kekar, Professor Basson, ladies and gentlemen, good afternoon. As you heard, it's my purpose this afternoon to discuss gender and outcomes in the first three cohorts of Garfield AF. Before I continue, please take note of my disclosures. The background to this inquiry are that women with atrial fibrillation are reported to be at higher risk of stroke than men for reasons that are rather ill-defined. In an earlier analysis of the Garfield AF baseline data by gender, it was established that the rates of anticoagulant use were not different in men and women, and that anticoagulants were underused in both men and women at high risk of stroke and overused in those at low risk. I intend to present data that are derived from cohorts 1, 2, and 3, a total of almost 29,000 patients, and compare the similarities and differences in outcomes at 1 year in the Garfield AF registry. And further, we might consider how these data might direct future analyses and research. The baseline characteristics of men and women in the Garfield AF registry are different. You can see that women were about 4 to 5 years older than were men, and that over 75 years of age, there were almost 47% of women and only 30% of men. If we look at vascular disease, unsurprisingly, men have a higher incidence at 17.7%, whereas only 12% in women. The mean CHA2DS2-VASc score was, of course, higher in women at 4.0 compared with 2.6 in men. The other characteristics were similar with the exception of previous smoking history, which was discussed by Professor Basson, which, as you can see, was far higher in men than in women. Looking at the CHA2DS2-VASc score, you'll recall, of course, that female gender automatically adds 1 point to women with regard to the CHA2DS2-VASc score, and therefore there are no women with a CHA2DS2-VASc score of 0. And the likelihood of a CHA2DS2-VASc score of 1 in women is much lower than that in men. Otherwise, the CHA2DS2-VASc score is relatively evenly distributed, with perhaps an excess at the higher end related to the older age profile associated with female gender. We've already seen the distribution of Hasbled with regard to the population as a whole, and there is little difference between women and men. The use of the distribution of the CHA2DS2-VASc score with regard to the use of anticoagulants is shown on this slide. And we can see that at this time point in the collection of data, about 15% or so of the population are treated with novel oral anticoagulants. We can see that there is little difference between the use of these medications in men and women. We have to compare, of course, not the CHA2DS2-VASc score 0 women to men, but the CHA2DS2-VASc score of 0 in men with the CHA2DS2-VASc score of 1 in women. And there we can see that, for example, the vitamin K antagonists are more or less used similarly, and there are slightly fewer women who are anticoagulated with novel oral anticoagulants compared with men. The overall use of antithrombotics, including aspirin or other antiplatelet drugs, is very even. There's a similar comparison to be made when we compare CHA2DS2-VASc 1 in men with CHA2DS2-VASc 2 in women, and so on. So that the use of anticoagulants is really very evenly distributed between men and women in the Garfield registry. We can also, of course, look at the influence of the Hasbled score with regard to the use of anticoagulants, and we saw that from the population as a whole, there was a reduction in the use of anticoagulants when the Hasbled score increased. Here I'm showing only data for the low range of 0 to 2 and the higher range of Hasbled 3 or more. And you can see that the total use of anticoagulants drops by approximately 8 or 9% for those who have higher Hasbled scores. But curiously, this is made up for by an increased use in antiplatelet drugs, which of course is predominantly aspirin, so that even in patients with a high Hasbled score, in both men and women, only about 5% of the total population receives no antithrombotic medication, even though the use of anticoagulants is somewhat lower. Now looking at the distribution of the use of anticoagulants around the world, divided by gender, women on the left and men on the right, we can see that there really is very little difference if we make this comparison for the whole cohort of women and men in Europe, and similarly for those in Asia, similarly in Latin America, North America, and other parts of the world. There's a slight difference perhaps in other parts of the world, but it amounts to only 2 countries and a relatively small number of patients. Now turning to outcomes, the outcomes illustrated on this slide are 1-year event rates. And we can see that stroke and systemic embolism, major bleeding, and all-cause mortality is numerically higher in women than in men, with not very great differences with regard to major bleeding and a more obvious difference with stroke and systemic embolism and all-cause mortality. But if we look at this in terms of the adjusted data using adjusted hazard ratios, we can see that there does appear from the perspective of the point estimates to be a fairly large effect with a adjusted hazard ratio for stroke and systemic embolism of 1.21 and with major bleeding 1.25. Neither of these values are statistically significant. And turning finally to the influence of anticoagulation, we can see with these adjusted hazard ratios that there is a marked difference between men and women with regard to the response of anticoagulation, with the stroke and systemic embolism hazard ratio of 0.39 when anticoagulant in favor of anticoagulation in women and in men, and 0.80 in women. So we can see that there is some difference in these scores with regard to the use of anticoagulation, and just to emphasize it, it is in men that we see the anticoagulant effect. So let me summarize the data by saying that men and women recruited into Garfield AF have differing epidemiology, similar risk scores, and receive similar anticoagulant treatment, that there are small differences between men and women in the incidence of stroke, bleeding, and all-cause mortality, that the hazard ratios for stroke and systemic embolism and bleeding are higher in women than in men, and that these are interesting observations which require further investigation to discover why women do seem to have worse outcomes than do men and do not respond well to anticoagulation. Thank you.